let's approach metabolism or biotransformation. When we look at metabolism, pretty much we have three scenarios shown in the diagram biotransformation of drugs. The whole idea of biotransformation is to render the drug more water soluble. Notice, therefore, in the definition, we are nowhere saying that metabolism's purpose is to turn off a drug, to inactivate it. We are simply stating that metabolism's purpose to render a drug more water soluble so that like this it will be easily excreted. What the figure therefore shows you is that really metabolism, as far as activity of a drug goes, can give rise to three scenarios. A drug through metabolism might be inactivated and then the inactive metabolites excreted. But for several drugs that we'll encounter throughout the syllabus, that metabolism may actually give rise to active metabolite. Understand by this, new form of the drug, metabolites, that still have an effect that will add up to the effect of the parent drug itself. And in some cases, a drug may be really a prodrug. Prodrug meaning it's not active as is, it depends on metabolism to be turned on and have an effect. So metabolism really is not defined based on activity of a drug. Metabolism is simply defined as a process whereby drug molecules become more water soluble. There are two types of biotransformations, two types of metabolism. Pharmacologists refer to them as phase 1 and phase 2 metabolism. It would have been nicer to call them type 1 and type 2 if you wanted to rename them, since really when you say phase you might think that there's a chronology to them and that you must do first phase 1 before you do phase 2. This is not the case. Phase 1 may occur alone, phase 2 may occur alone, phase 1 may be first, phase 2 may be second, and sometimes there might be no metabolism whatsoever and just excretion of the parent drug. So as we look at the biotransformation classification, let's have an idea of their definition. Before you throw yourself in the syllabus, let me show you on the board a little bit what phase 1 and phase 2 overall would be about. Let me invent a drug, and you don't have to draw this on your syllabus, promise, just look. Imagine this is a drug right here. What a phase 1 reaction will do is modify that drug. And modification of the drug would mean literally you're going to break that molecule in pieces. You know, maybe you'll end up with a piece that would be like this, why not, plus another piece that would be like that, and so forth. You give rise to new structures in phase 1. There's a modification. If there is a modification, a key aspect in our body, we're not drug companies, although some people might feel they are if they take too many drugs, but overall, the idea is our body will never be able to recombine these pieces and come back to the parent drug. Can't work. These are irreversible reactions. Contrast, a phase 2 is what we call not a modification, but a conjugation. And what a phase 2 reaction does is take that same drug and it does not change it in structure at all. All it does is attach to that parent drug some endogenous compounds, and I'm going to represent them in red here, some endogenous compounds that will just encircle that molecule to render it more water soluble. The key point here is that if I was removing those endogenous compounds, my drug is still there right in the middle. Conjugation is a reversible process that could give me back the drug I started with. So that's why we talk about a phase 1 and a phase 2 type of reaction. If we go back to the syllabus, let's define first phase 1 type of reactions. By definition, we say here in words, you now saw it on a diagram, that it's a modification of the drug molecule. And the type of organic reactions that would modify drug structures are oxidation, reduction, or hydrolysis. Rest assured, we don't need to become chemists again to understand what the boards are after here. What the boards are generally after is a key system that does oxidoreduction for us, which are cytochrome P450s. And cytochrome P450 enzymes have some key points associated with them. They're localized in the smooth endoplasmic reticulum of cells. Now, you know, histologists, if they're fractionate cells by ultracentrifugation, call that the microsomal fraction. That's why an old name for them was to call them microsomal enzyme oxidizing system, MEOS. And those P450s have two biochemical requirements. If they need to oxidize, they require oxygen. And if they need to reduce, they need some hydrogen. They get that hydrogen from NADPH. Do you remember a key enzyme in biochemistry and genetics that produce NADPH? I hope you're thinking glucose 6-phosphate dehydrogenase of the HMP shunt. And you remember some people might be deficient in that enzyme, potentially causing a pileup of drug that may require some reduction. Now, oxidoreduction is a general term. So in the syllabus, we give you two forms of oxidations, just so that you have vocabulary, certainly not to especially understand them chemically. Hydroxylation is a classic form of oxidation, and so is dealkylation. Key issue about these enzymes, there's hundreds of cytochrome P450s. They're lumped into families, actually about 13 of them are known. We're lucky for drugs, for xenobiotics as we call them, chemicals that come from outside the body. Really the first three families are going to be relevant. Families of P450s are given a number. So CYPs 1, 2, and 3 are going to be the three major families that will metabolize most of the drugs you would encounter in the physician's desk reference book. Each family, to arrange everything, is subdivided in subfamilies, which are given letters A, B, C, D, E, and so forth. And within those subfamilies are the individual enzymes themselves, given again a number, resulting, if you look at the table entitled cytochrome P450 isozymes, in a number of acronyms for P450s, such as in your table 1A2, 2C9, 2D6, 3A4, being here the major enzymes we're going to discuss. So if we pick on CYP1A2, for instance, it would tell you 1, it's the first family of P450, it's the subfamily A of a series of subfamily, and it's the second member of that subfamily as an enzyme. Having said this, a big problem with those P450s, one P450 may metabolize many different drugs, and vice versa. A single drug might be metabolized by several P450s. This opens the door to drug interactions, and this is where, of course, most of your P450 emphasis would be for a board review. The table and how it's built. After giving the name of the P450 on the left column, we give you a substrate example. Understand by this is one out of many examples of drug that would be metabolized by this enzyme. Theophylline in the table is metabolized by CYP1A2. So is acetaminophen. Don't please memorize from this that only theophylline and acetaminophen are metabolized by 1A2. Many other drugs would be, but those are two key ones for which we'll see some points of relevance on the exam. The third column shows at inducers of enzyme. Induction is the process whereby chemicals can increase gene expression of enzyme. Check out your biochemistry for that point. And when you increase gene expression, you have more copies of the enzyme available, therefore you speed up metabolism. An inducer of 1A2 could be smoke. Smoke has aromatic hydrocarbons, one that we incriminate for a number of toxicities and cancers in pathology is benzopyrene. That's a great example of aromatic hydrocarbons. But smoke, keep in mind there, doesn't have to be smoked from a cigarette. It could be smoke from food you char-broiled on the barbecue, or it could simply be you're in New York City and you breathe smoke your entire life, and this smoke would definitely induce CYP1A2 and speed up metabolism of drugs like theophylline, acetaminophen. Foods might be inducers too. In that table we show you that cruciferous vegetables induce the enzyme 1A2, would speed up metabolism of theophylline and acetaminophen and result, of course, in quicker metabolism, decreased effect of the parent drug, and more accumulation of the metabolite. By the way, cruciferous vegetables are cabbage, broccoli, that type of things. The fourth column shows you inhibitors of the same enzyme. Notice for right now how certain antibiotics are classic inhibitors of 1A2. I would certainly stress macrolides in the story for 1A2. And the final point is about genetic polymorphisms. And genetic polymorphisms reminds us that not everybody will have the same metabolic profile for drugs. Some people may be referred to as slow metabolizers, others might be referred to as fast metabolizers. Well, to complicate the matter, not all P450s show genetic polymorphism. And there are two key enzymes in that table that have genetic polymorphism. They're 2C9 and 2D6. So this is for the structure of the table. We're not going to use every single example of that table, otherwise it would take us forever. But let's pick on some of the major one, and like this you'll see where we're going as far as your boards are concerned. And we're going to start with literally theophylline. What is theophylline? A drug. I know it's a drug, but hopefully you remember that theophylline is a drug that's used for COPDs, for chronic obstructive pulmonary diseases. Example of COPDs, in pathology, things like chronic bronchitis, very heavily associated with smoking, but also things like asthma, emphysema, bronchiectasis. Theophylline is often used in people with chronic bronchitis out of all this. It's used also in IV form for people with status asthmaticus. Theophylline is a good bronchodilator. Now, theophylline is also a drug that is unfortunately very cardiotoxic. You see, the receptor it binds to, which is called an adenosine receptor, is a receptor whereby the chemical adenosine in our body slows the heart rate. Theophylline is an adenosine receptor antagonist. As an antagonist, it will cause potentially tachycardias. It is by the same mechanism though, and also phosphodiesterase inhibition, that it bronchodilates. Promise, we'll see all this later on in the book, so you don't have to write everything I'm saying. Just start swallowing it and drink it so that it comes back out at the right time. The issue is theophylline will have to stay within very strict blood concentrations. As a matter of fact, when a patient is placed on theophylline, we must do what we call therapeutic drug monitoring. 1, you want enough theophylline to have a good bronchodilation. 2, you don't want too much of it, because otherwise you'll have a heart attack. If you have a heart attack, you don't have asthma anymore, obviously, but it's not a good approach for management of asthma, obviously. Theophylline is induced in its metabolism by smoke. So if you were imagining someone who is smoking heavily or who eats barbecues all the time, then you could imagine that the time theophylline stays in the body is very short. That may actually require adjustment in the dosing of theophylline. But your worst issue with theophylline is what would happen to its toxicity if you were inhibiting its metabolism by one of the 2 antibiotics given in the table, namely quinolones or macrolides. Then you would imagine that theophylline building up in that patient's body would be very likely to cause some cardiotoxicity. That cardiotoxicity shows up in terms of ventricular arrhythmias, which are life-threatening. The antibiotics I like to think of here are macrolides. Macrolides are often used for upper respiratory tract infections. What do people with chronic bronchitis and asthma often suffer from? They certainly often suffer from upper respiratory tract infection. Imagine they're on theophylline, they go to see their general practitioners who may not be aware that they're taking that theophylline, and they're given macrolides. Or who knows, even worse, they have macrolides left in their bathroom from their wife or children who took them for whatever upper respiratory tract infection they had last winter. Then taking those macrolides could result in such a buildup of theophylline as to get cardiotoxicity, and some deaths have occurred that we've seen in ME's office, in medical examiner's office. So theophylline, a great example to know for the exam and for real life. Let's work a little bit on acetaminophen while we're at it. You know, acetaminophen, Tylenol, classic painkiller, classic fever-reducing drug, not an anti-inflammatory, works mainly in the CNS, and absolutely available at any amount you want over the counter. Acetaminophen is metabolized by 1A2. Acetaminophen itself is not very toxic, but acetaminophen is metabolized in the liver to a very nasty metabolite called a free radical. That metabolite can damage the liver. The metabolite is obtained because of P450 1A2 metabolizing acetaminophen to that free radical. Here it's not inhibition you're going to worry about. What you're going to worry about is induction. any situation that could induce acetaminophen's metabolism could result in a buildup of that free radical and severe liver failure. Well, inducers here we have cruciferous vegetables, smoke, and those really are unlikely to be seen in very, very large amount. Your big inducer for acetaminophen on your exam and in real life is chronic alcoholism. Chronic alcohol, by inducing P450, is very likely to cause acetaminophen in the liver, probably already damaged of that alcoholic, to cause so much free radical accumulation as to result in a fulminating hepatitis. Induction or inhibition of the P450 can result respectively in a decrease or a buildup of the parent drug, or respectively an increase or a decrease of the actual metabolites. Now for 2C9 we give you some examples such as phenytoin, warfarin. A relevance is the genetic polymorphisms issue. I won't stress those too much. I'd rather go straight to 2D6 because 2D6 is a classic enzyme for most cardiovascular and CNS drugs. Main chapters in our board review. There are no known inducers of 2D6. There are some inhibitors, mainly haloperidol and quinidine. But a key point in 2D6 is the genetic polymorphisms. Most CNS and cardiovascular drug will have very variable pharmacokinetics in our patients because of those genetic polymorphisms. You will have people who are slow metabolizers and who therefore will very readily pile up CNS and cardiovascular drugs and tend to get side effects, toxicities of those medications. On the other hand, you'll have another patient who would take that very same dose and hardly have any effect whatsoever because of being a rapid metabolizer. It is an issue because of its involvement with many, many drugs that might be prescribed. Of course, most patients, you can tell looking at their forehead whether they're slow or fast metabolizers. What we have to hope for is for a molecular biologist to make a user-friendly and appropriately priced device to actually type the metabolic profile of patients. And this is really on our doorstep. It'll be very helpful for those of us who might want to prescribe cardiovascular or CNS drugs to have an idea as to the metabolic profile and adjust individually the dose to very much tailor our dosing to the patient that is about to receive it. For 3A4, there the most important point of this enzyme is its relevance in metabolism of pretty much 2/3 of any drugs we prescribe. PDR, by the way, in the table refers to Physician's Desk Reference, the book in which you find all the drugs that are FDA approved in the United States. Well, 60% of the drugs use somewhere in their metabolism 3A4. Here we don't worry about polymorphism. We do worry about inducing or inhibiting the enzyme and the consequences on the parent drug. Well, drugs that induce or inhibit 3A4 are simply referred to as general inducers or general inhibitors, just because of the far-fetched effect they will have overall on pretty much any medication that would be administered. They're given in the table with a little star, general inducers, and a little cross for general inhibitors, referring to the fact that under the table in your syllabus you see a list of those drugs. These are must-know fact. You just memorize those lists. Those lists will help you greatly for drug interaction type of problems. General inducers, you see, are mainly the group of anticonvulsants for the exam. That is namely drugs such as barbiturates, phenytoin, carbamazepine, which classically will be used chronically for the lifetime of that patient and forever will result in a liver that is filled with 3A4 and a very rapid metabolism of 60% of our drugs pretty much. General inhibitors will very much be associated on your exam with anti-ulcer agents, particularly the drug cimetidine and the drug omeprazole. Cimetidine is over the counter, as you know, as an anti-ulcer medication. Omeprazole is the classic proton pump inhibitor. There are many other general inducers and inhibitors, and one of relevance is to talk about alcohol a little bit. When patients take alcohol, alcohol is taken in huge amount. I'm not talking volumes here, I'm talking the concentration of alcohol in a drink. Think of drinking a beer, for instance. If some of you have ever looked at the beer can before you swallow it, you might see that the alcohol content of beverages is given in percent. We're not talking here milligrams or micrograms per ml. We're talking grams per deciliter or grams per 100 mLs. Now, what is 100 ml? It's about 4 ounces. How much beer is drunk by maybe an average football fan, let's say? Certainly not 4 ounces. You're talking maybe a couple kegs. No, I'm exaggerating here. But certainly grams and grams of alcohol will get in the body. Those grams of alcohol, they're going to need to be metabolized. Imagine you have that little drug in microgram that is also trying to be metabolized as you drink grams, thousands of times more alcohol. What do you think is going to happen to metabolism of that drug? Obviously, the alcohol is going to totally inhibit the metabolism of the drug when it's drank acutely. So acute alcohol is a classic inhibitor of drug metabolism. Does it stop here, alcohol for drug interaction? Well, an interesting aspect of alcoholism is the fact that people may do that chronically. Imagine now you're in a situation where you're not watching the Super Bowl and having plenty of beer on that one day exceptionally, but rather you drink alcohol on a daily basis. Because your liver is exposed to grams of alcohol on a daily basis, the liver will adapt. And the way it will adapt is by increasing the number of enzymes that will metabolize the alcohol, essentially inducing the gene expression of enzymes for metabolism. It turns out from this that chronic alcoholics don't see an inhibition of drug metabolism. They rather see an induction of drug metabolism, meaning a chronic alcoholic actually will have a speedier, faster metabolism of its drugs. Obviously, alcohol, whether acute or chronic, is likely to cause drug interactions. As a matter of fact, when you look at any drug pamphlets or any literature about drugs, more often than not, you'll see that it'll say avoid taking with alcohol because of encountering all these drug interactions. Shall we pick on one? Think of a key one for the exam. What if I was giving you acetaminophen and you were a chronic alcoholic? What would happen? You remember how chronic alcoholics have an induced enzyme system? And you remember further that acetaminophen's metabolite is what is hepatotoxic. You know that chronic alcoholics should avoid, of course, acetaminophen. So let me give you a little trick I've heard on through feedback from a student recently. The same point of acetaminophen hepatotoxicity, but this time in a person drinking alcohol acutely. In other words, not a chronic alcoholic. What would happen to hepatotoxicity then? Don't forget, acute alcohol inhibits enzyme metabolism, thereby preventing acetaminophen from causing hepatotoxicity. Be careful how you read the question. Eventually, just make sure you remember, acute alcohol inhibits, chronic alcohol induces enzyme metabolism. Let's pick on another thing that could be part of our diet and sometimes we don't necessarily associate with drugs. You see in your table as a general inhibitor grapefruit juice. When do people drink grapefruit juice? Maybe when they come from Florida like I do. Most often people drink grapefruit juice because they're on a diet. And people who are on a diet, more often than not, it's not by choice. It's because they were told you go on a diet or you will have a heart attack or a stroke because your cholesterol is too high. So people who are on a diet often take cholesterol-lowering drugs. In the margin of your syllabus, you see of drugs called statins. Statins are classic drugs used to lower cholesterol, lovastatin being the prototype. And lovastatin, if it is inhibited in its metabolism, and other statins too, by the way, such as would happen with grapefruit juice, would pile up in the body and cause significant toxicity. Toxicities of statins, they destroy your liver. That's not very nice. And certainly they can destroy your muscle, causing rhabdomyolysis, which in turn, releasing myoglobin in the blood, will result in renal failure. There's no doubt that if you're on a statin for lowering cholesterol, you must not take at the same time grapefruit juice. Issues of rhabdomyolysis have happened in the past to the point that it says in any prescription with statin to avoid taking grapefruit juice. You know what we do generally for drug administration? When there's an issue with food, we're going to make sure that the drug is administered as far away as possible from any food intake. And for statins, when do you administer them? Statins are always given at bedtime. Normally grapefruit juice, you don't take it at bedtime. It's something you're going to do first in the morning. It's very bitter, so that like this you get it over with as fast as possible. Sorry for Tropicana. But that's the idea. The farther away from food intake, the better for the statin, particularly from grapefruit juice. Well, that's where we'll leave those P450 isozymes, and we'll remind ourselves of those general points as we go through the syllabus. We need to answer ourselves another point. Still in phase 1 biotransformation, does it mean that P450s are the only enzymes for your exam that do modification of drug structure? Well, the answer to this, you guess, is no, not at all. If P450s are microsomal enzymes that do most oxidoreduction type of reactions, there are non-microsomal metabolism routes that can be taken by drugs. And on the following slide entitled Phase 1 Biotransformation, you see 3 major forms of non-microsomal metabolism, essentially meaning not mediated by cytochrome P450s. Hydrolysis is not mediated by P450s. It's mediated by 2 types of enzymes called esterases and amidases for our exam. Esterases, their relevance you'll see quickly, is the fact that they're genotypically variable. There are slow esterases and fast esterases metabolizers out there. Meaning if a drug is metabolized by esterases, you need to have a rough idea as to whether your patient is fast or slow metabolizers, so that like this you would know how to adjust the dose and what duration of action to expect. We'll talk about hydrolysis and those enzymes when we review local anesthetics together. It'll be in the CNS section. Monoamine oxidases are a form of oxidation that is not P450 mediated. It's mediated by enzymes called MAOs. And MAO enzymes are found in neurons that tend to metabolize mobile pool. You know that inhibitors of MAO enzymes are used as antidepressants. So they're just another example of non-microsomal metabolism. And finally, as another tricky point about alcohol, we've just talked about alcohol and its effect on cytochrome P450s, acutely inhibiting these enzymes, chronically inducing those enzymes. But the reality is P450 enzymes are not the main route of metabolism of alcohol itself. Alcohol itself as a chemical is metabolized by dehydrogenases. You know those famous enzymes biochemists tend to have palpitations about because dehydrogenases give you compounds like NADH, FADH2, from which we can have electrons to transport in the mitochondria's electron transport chain to derive ATP. As a matter of fact, do you remember how much ATP we get from alcohol? Or how much energy? 7 kilocalories per gram. You learned from your biochem. Well, those dehydrogenases are relevant in alcohol metabolism for also being genotypically determined. Not to say that P450s don't play a role. Excess alcohol are metabolized by a cytochrome P450 that's called 2E1. You see this in your syllabus. That's it for phase 1. Phase 1 could be followed by phase 2, or phase 2 biotransformations could occur by themselves. You remember what a phase 2 is? A phase 2 does not modify the drug structure, rather a phase 2 conjugates the drug with endogenous compounds. The whole idea is those endogenous compounds are already very water soluble. And if you hide a little droplet of oil, your lipid soluble drug, with plenty of molecules of water around it, then you know that overall the only thing the body will see is that water molecule on the outside, and they won't see the lipid droplet in the middle anymore and get rid of it. How do we put endogenous compounds on top of our drugs? Well, we do this through enzymes called transferases, and there are many different types of transferases. The first type in your slide is glucuronidation. Glucuronyl transferases are found in any tissue. They're certainly high in the liver, but they're also found in the gut, they're found in the kidney. And glucuronidation is the main mode of phase 2 reaction. The same way as you learned P450 was the main mode of phase 1 of modification of structure type of reaction. Glucuronidation, some key points, it is inducible. The general inducers you saw for P450s also induce glucuronyl transferase activity, so that, for example, a barbiturate drug would also speed up glucuronidation of drugs. And the second point about glucuronidation is its low level, low activity of glucuronyl transferases in neonates. This means a very key point. In neonates, if you know of drugs requiring conjugation by glucuronidtransferases, they have to be avoided at all costs, since those drugs would accumulate and potentially cause significant toxicity. By the same token, remember how bilirubin itself accumulates in neonates because of lack of conjugation, resulting in physiological jaundice of a newborn, something we try and pretty much take care of by trying to have a baby that's not too premature, or if it's the case, to have the baby staying under UV light to break down that bilirubin that causes jaundice. So glucuronidation being obviously an issue in neonates. By the way, in your pathology syllabus and also in your biochem syllabus, you'll see 2 genetic disorders that will also involve issues with glucuronidtransferase activity, and those are Crigler-Najjar syndrome, very much so, and Gilbert's type of syndromes. In Crigler-Najjar syndrome, your key issue is potentially a complete absence of glucuronidtransferase activity. Generally, this is associated with kernicterus in the neonate. Acetylation is another form of biotransformation that is a conjugation. Relevance of acetylation on the exam: it is genotypically determined. You know the drill by now. It means slow and fast metabolizers. And in slow acetylators, certain drugs may accumulate and cause toxicity. Your syllabus tells you of 3 important drugs, which in slow acetylators will result potentially in SLE-like syndrome. Those drugs are hydralazine, procainamide, and isoniazid. Hydralazine is an antihypertensive, procainamide an antiarrhythmic, and isoniazid an antitubercular medication. What is SLE-like syndrome? You know SLE, systemic lupus. Lupus is normally an autoimmune disorder. And if you remember your pathology well, autoimmune disorders, classically in the United States, are found pretty much ratio 10-1 in female of childbearing age, and particularly in African Americans. Lupus, as an autoimmune disorder, results in type 2 and type 3 hypersensitivity reaction that are systemic. And those immune inflammatory responses cause damage to a number of tissue. You know, a classic presentation are rashes. Those rashes are not going to kill you. A classic rash would be a malar rash on the cheeks, bridging the nose. What is really troublesome as organ toxicity in lupus are kidney toxicity and blood toxicity. The kidney toxicity causing eventually renal failure. You know, there are 5 different types of nephropathies associated with lupus. I'll let you discover them happily in PATH. And also, as far as blood toxicity, the key issue of having infection. When we say a drug causes SLE-like syndrome, we mean exactly this. We mean the drug can cause multiple immune responses in that patient to the point of mimicking a lupus picture. How different is it? How can I know? Well, of course, if you already know the 3 drugs, hydralazine, procainamide, and isoniazid, you already have an idea. If you start seeing rashes, kidney issues, CNS issues, blood toxicities such as agranulocytosis, it's probably due to the drug. But if you want to really contrast them, there are 2 key points. One, the epidemiology. A drug-induced SLE is not going to be mainly seen in childbearing females or mainly Black American. It could be anyone, male, female, any ethnicity. Other key point, when you stop the drug, the effect goes away. Of course, in lupus, it's not the case. And as far as laboratory measurement, very important for your exam, and write this time in your margin, because I believe we haven't written it yet in the pathology book. We look at antibody profiles in people with lupus. Classic antibody profile, it's part of a group of autoimmune disorders that have anti-nuclear antibodies, ANAs. Drug-induced SLE will cause positive ANAs. So screening tests for lupus would also show positive in people with the drug-induced form. It is at the level of specific autoantibodies that you see a key difference. In drugs-induced lupus, we see antihistone antibody, antihistones. In the lupus as a disease, we don't see antihistones. As you know well, we see what? I hope you're saying double-stranded DNA and anti-Smith, anti-SM type of antibodies. Idea, if you see those SLE-like syndrome, well, of course, to remove the drug and not treat with steroids. That's your key point about acetylation. Sulfation is a form of conjugation that is used particularly for steroid hormones, and glutathione conjugation, this is important for drugs that produce free radicals. Glutathione is a free radical scavenger. You already know one drug that causes free radical and hepatotoxicity, don't you? I hope you're telling me acetaminophen. We worked on acetaminophen and its P450 metabolite causing free radical damage in the liver. Well, glutathione is very important in trying to decrease the acetaminophen hepatotoxicity. It's a little peptide. We'll talk more about it towards the end series of the pharmacology lectures.